cut my presentation a little bit short. But after this, we'll go for lunch, some break, and we'll try to count the lunch hour. It was 1 hour and a half, right? If we can make it like 1 hour, 15 minutes to have some time, take a look at the booths. Without that, we still, believe it or not, we're still good morning. I'm going to talk about a topic, that's why I'm cutting my time, because already been discussed multiple times in different ways, but adaptive ventilation mode. So the plan is to talk what are adaptive modes, how they work, why should we use them, and if any evidence behind it. So adaptive modes are closed loop systems, meaning the ventilator accepts some positive and negative feedback and adjusts its output. It's called optimal or intelligent target schemes, as you heard to Professor Chadburn in the morning. Why are they called adapt? Because they're supposed to adapt to the patient. So it's not a real scientific name. Anyway, I just want to stress that it's not only one mode. It depends on what the patient is doing. So if the patient is paralyzed, no effort whatsoever, it's pure pressure control mode. If the patient is spontaneously breathing, doing some of the work and the ventilator doing the rest, it's a form of intermittent mandatory ventilation mode. And if the patient is doing all the work spontaneous breathing, it's purely pressure support mode. There's so many different names. As you can see here, I'm not allowed to say the name of the trademark of the manufacturer, but ASV1, ASV 1.1, IntelliVent ASV, AVM only, or AVM1, AVM2, work of breathing, optimal ventilation, adaptive minute ventilation, and most of those ones that you have see the blue arrows, they're exactly the same. The only ones that are different now are ASV 1.1, AVM2, IntelliVent. All right, so this is like just basically physiology quickly, that our respiratory change, our respiratory rate changes according to our respiratory compliance and resistance in a very predictable way. That's a normal. So if you're COPD, you're going to take a deep breath at very low rate. You're normal here like 15. If you're having restrictive lung disease, you will be breathing fast and quick. Now, those modes work with an algorithm, and I am by no means able to really explain to you how those algorithms work. Those are engineering and much complicated computer people that I can't understand. I'm just a simple clinician. So I'm going to say that this algorithm depends on the tidal volume, tidal pressure. If you multiply them by together, you get the tidal power, breathing power, and we'll talk about this. So there is some work, really complex work behind it. It's not very. If you look at most of the adaptive modes, they give you this curve between the tidal volume on the y-axis and the respiratory rate on the x-axis. And it defines for you, so you either to reduce your work of breathing or the energy you use to work, is you either breathe very slow at a very high tidal volume, or you breathe very rapid with very short tidal volume. And your optimal way of breathing would be like that in the middle here. So according to this, the ventilator gives you that nice kind of square, and always gives you like called the safe window, that white window. So the ventilator, according to the algorithm, will determine what's a good tidal volume for that person and what's a good respiratory rate. If the patient goes, so if you go to number 1, which is down here, if the respiratory rate, if the tidal volume goes very low, now you're breathing dead space, which is not good. If you go to the left, number 2, that's a very low respiratory rate, you're becoming apneic, so that's not good. If you're breathing very high tidal volume and probably high pressure, you're barotrauma and volutrauma, forms of ventilator-induced lung injury, so it's not good too. And if you go to number 4, you're breathing very fast, you're going to probably develop auto-PEEP, which is not good. So according to this, the ventilator determines, okay, you should stay in the middle of that square. Same picture here. So what happens if the patient goes a little bit high tidal volume and less respiratory rate? The first yellow cross here in the top. Well, the ventilator say, I want you to go to the target, to that blue point. So it will reduce its inspiratory pressure and increase the respiratory rate, try to match the blue point. What happens if the patient is actually on the left side here? so low respiratory rate and low volume, it will increase the inspiratory pressure and will increase the respiratory rate. On the top right here, so now the patient is having high tidal volume and high respiratory rate. So the ventilator will reduce the inspiratory pressure. And the ventilator, yes, can determine that, oh, I'm going to reduce my mandatory pressure, my mandatory respiratory rate. But good luck, because if the patient is breathing 30, it's not going to tell the patient, oh, stop breathing. Like, you have to breathe in 20. It's not going to do that. If you're here in the bottoms right, again, now the volume is low and the respiratory rate is high, it will start increasing the inspiratory pressure. Again, the patient is already breathing above the ventilator target. But in a hope that once the patient starts increasing the pressure and the volume, he should probably quiet down. Oh, so we're talking about like little bit algorithms. ASV in the past it used the Otis equation. Very complicated paper. I tried to read it. If you find it, it's from the 50s. Can never understand it, so I'm just going to skip those equations. Then Mead is very recent, like in the 80s, did more work on it. Again, another simple equation that I'm not going to talk about it. But anyway, so that's how ASV changed its algorithm from ASV to ASV1, but it's still the same picture, the same kind of, just different algorithm. Now, different ventilator mode called the AVM, and if you can look, of course, the background, the picture is a little bit different, but it gives you the same safe window, same concept, but based on a different equation called the inspiratory power. So the ventilator determines the combination of the respiratory rate and tidal volume just based on a different equation. All right, and the ones that's not approved in the US yet, it's basically an ASV, but with some automation of the FiO2 and the CO2 elimination. So it's kind of ASV on steroids a little bit. Okay, so what are settings, what we're going to do, how we're going to set it? For clinicians, you have to do the gender and height to get the ideal body weight. You have to dial the percent minute ventilation. So it's somewhere, it's very big difference. You can it gives you option from 25% to 350%. So what the hell that mean? Usually 100%, meaning 100 milliliter per kg ideal body weight. You can increase it or decrease it according to your CO2 elimination or the patient's effort. You dial the FiO2, you dial the PEEP, you dial the expiratory sensitivity as if you're dialing pressure support if the patient's spontaneous breathing. Of course, you dial the rise time that we sometimes forget about it. Some ventilators, of course, have automatic rise time. Now, in the IntelliVent, you dial the SpO2 target and the end-tidal CO2 target. And according to this, the ventilator will adjust the minute ventilation by itself, again, within a limit. So you don't have to do 100, the PCO2 is 70 and the pH is 7.1. So let me go to 120, 130. It would do that for you. So it's kind of like cool. All right, what does the ventilator know? How does the ventilator know that we don't know? Actually, we should know more than the ventilator, but we don't. The ventilator calculates respiratory mechanics for you in a different way. Like first, we already heard about the time constant, expiratory time constant, which is the way the lung empty or the respiratory system empty from 100 to 60 to 37%. So that's one time constant, which is basically product of compliance and resistance. So the ventilator does not want auto PEEP. So try to allow at least 3 to 4 times time constant for exhalation to avoid auto PEEP. But according to its calculation of respiratory mechanics, it decides by itself tidal volume, so you don't have to dial tidal volume, you don't have to dial respiratory rate, you don't have to dial respiratory pressure or I to E ratio. And again, if you have the IntelliVent, it will do the FiO2 and PEEP for you. I never used IntelliVent again because it's not in the US. What I don't like about, I think it's awesome that there's automation adjustment for PEEP. I think that we need that, but they do it according to the PEEP FiO2 table, which I am personally against. Okay, so we wrote this couple of years ago about trying to get some consensus, some settings or guidelines in using ASV. And according to the studies, we found that If you're having a normal lung, somebody intubated for drug overdose or surgery, whatever, it's okay to start at 100%. If you have somebody in ARDS, you're probably going to start a little bit higher than 100%, 130, 100, you know. Of course, if patient's septic, tachypneic, you might need more. And then you go adjust a little bit later. So the bottom table here, it shows you like if a normal lung, and if you adjust it at 100%, you will get about 7.3 milliliter per kg, which is not bad. Usually now the recommendation below 8. In ARDS patient, we always worried about the high tidal volume, etc. It actually delivered 5.8 milliliter per kg. In COPD, actually, it delivered very high tidal volume. All right. I'm going to skip through this because it's really not that relevant. My point of this screen is using those automated or intelligent modes, you can start from as soon as you intubate the patient, you put them on it. During the recovery, during your weaning, you can still use one mode. Instead of starting the patient volume controlled and switch him pressure control, then later on do spontaneous breathing trial with pressure support, just go from A to Z. Okay, benefits. We're going to talk a little bit about lung protection, mechanical power, comparing to other conventional modes of ventilation, weaning and automatic adjustment and ventilator adjustment. Of course, you will never going to be able to read this, and that's why I put them. You will find a lot of slides like this, so just trust me what I tell you, okay? I actually couldn't read them without mic. Okay. This is basically a slide comparing IntelliVent, comparing the transpulmonary driving pressure that we talked about yesterday and transpulmonary mechanical power, and compared to conventional mode, and it showed that basically IntelliVent reduced the transpulmonary driving pressure and transpulmonary mechanical power, which is the stress on the lung. Almost very similar here, ASV versus non-ASV. Most of those studies, to be honest, are very small pilot trials, so it's nothing like to be 100 to 100 patients. They're usually like 20, 30 patients. Again, the same here, compared to pressure control, and it reduced the mechanical power and the mechanical driving pressure. This is a study simulator study we did in our journal comparing AVM to pressure control in a normal lung setting, like normal compliance, normal resistance. So we compared AVM to pressure control to volume control, and we found that AVM reduced. So basically, we tried to match the pressure control and the volume control to the same minute ventilation that we're getting with AVM. And it showed that reduction. We calculated the mechanical power, and it showed the reduction of the mechanical power. Then we repeated the same study because we had enough time. We did it in ARDS patient, different severities of ARDS, compliance 40, 30, 20, and compared it again to volume control and pressure control. So we discovered that AVM reduced the mechanical power, followed by volume control, followed by pressure control. So an opponent of the pressure control mode, actually, I was not happy about that volume control does better. Another study, again, small study in COVID, comparing IntelliVent at conventional ventilation. And as you can see, IntelliVent, again, reduced the amount, the intensity of breathing in those COVID patients. Most of those studies do not show any mortality benefit, and I will talk about this. Now, we're not going to go through this. I tried to highlight it, but I'm sure you cannot read it. So this is basically lots of studies. Most of the studies are done about with ASV, because ASV has been since the probably late 80s or 90s, early 90s. So there's lots of studies about ASV. Those are all studies, just take them from me. They're showing that they are at least comparable or maybe a little bit safer than conventional modes. Sorry, we don't really have time to go through all of those. But this study actually was, again, published by our journal. I think the author of the study is sitting somewhere here. Anyway, so this is a study we just finished a couple of months ago in Kwakini. We tried to compare AVM to regular pressure control mode. Small study, it was 22 patients. This is not peer-reviewed, not published, so take it with a grain of salt. within those statistics. I just calculated that's the average. So the mechanical power was pressure control. And these are not only ARDS patients, this was just a group of any respiratory failure patient. The average of pressure control was 23. Then when you switch them to AVM, it went down to 17.4. All right, most of the evidence of intelligent ventilation or optimal ventilation actually comes from weaning studies. And again, same article in the same journal showing all the evidence. It showed most of the time, actually, ASV does better and shorter time compared to conventional weaning, especially in post-operative CABG patients. I'm not sure exactly why do they pick CABG, because you would think, but anyway. Now the new thing is automatic oxygen adjustment. Then you would think in your brain, it's like, oh, that's something silly. Anybody can just stand by the ventilator, drop the FiO2. You will be, I mean, you all know that sometimes a patient is saturating 100%, and we go from 100% to 90% FiO2, a couple of hours later to 70. It takes like sometimes a day, you know. Anyway, all of those studies, there's like 6 studies showing that full automation of the FiO2 by itself actually helps the patient, reduce the time of being on high FiO2. Now, more and more evidence showing that hyperoxemia is dangerous. So I know we feel so happy when we get a blood gas. Oh, the PO2 is like 300, so that's good, you know. Actually, it's not good. It might be bad. We knew that about neonates long time ago, but I don't think we never really understand that's also dangerous in adults. This is about ventilator settings. Again, all what it shows that for you as a respiratory therapist or a clinician, it reduced the amount of you changing the ventilator, which is that's what you really need to do, you want to do. I know some people get scared. It's like, well, if the ventilator take over, he'll take over my job. No, I think it will help, especially during the COVID days when you have to go change your PPE every, it's so hard. But the ventilator adjusts the FI2 and some settings for you. I think it's great. Same, almost similar study here. I'm going to skip it. Now, this is the conclusion or the summary. Closed loop ventilation automatically adjusts some settings to keep physiological variables with target ranges. That's great. Times spent on optimal SpO2 targets is increased, preventing both hypoxemia and hyperoxemia. Now, the tidal volume, driving pressure, or mechanical power kept within the recommended protection ranges. Great. Problem is, studies demonstrate the potential of closed loop system to reduce the duration of weaning and mechanical ventilation. There is no clear evidence that these physiological benefits improve clinical outcomes. And that's the point, actually. Again, as I said, I think I said yesterday, we nowadays are suckers for mortality. So if something doesn't improve mortality, we just throw it out in the garbage. No, it's not everything in change mortality. So we have some clinical outcomes that might help later. Anyway, we need larger, multi-center, big studies. And with this, I am just going to stop. I hope I didn't take too much of your time. Thank you. That's a great question. Sorry. So to repeat the question, is the ASV 1.1, which is the current ASV, and AVM2, which is different from the AVM1, are they superior to the older versions? To my knowledge, it was compared in one clinical study. They compared AVM1 to AVM2, and it showed to be better. The other study was done by Rob here and simulated, right? It was simulated, and it showed like it might actually reduce the tidal volume and driving pressure. So are they better? They're supposed to be. Yes, sir. Right. Right. So they were modified, as you said, like to try to reduce mechanical power or power in general and to be in the protective ventilation. Yes, sir. So Steve is asking, since we have new versions, did they get it wrong? And my answer is, life is an evolution. If you believe in evolution, if we were monkeys before, did God get it wrong? I don't know. Well, Apple started with Apple 1, 2, 3, 4, and we're like in 15. I think it's just natural. The more we learn, the more, and especially with artificial intelligence, I'm sure there will be more versions. Yes, sir. Yeah. That's an excellent question. Jeff is asking, since ASV or AVM reduced the mechanical power, did it reduce the mechanical power because of what? Well, we have only tidal volume and pressures, right? So if we didn't change the PEEP, so we basically have tidal volume and pressure. There is one study that in their conclusion, it was because of the tidal volume. But in theory, if it's reduced the tidal volume, it also tried to reduce the pressure in theory. Because again, energy is volume times power and work more, or the opposite. So it's either volume or pressure. I think it's the volume. I could be wrong. If somebody knows the answer. Right. Excellent question too. So it depends if what's the patient's condition. Sorry, Graham is asking. What were you asking? He's asking a question I can't remember. I'm just gonna say any answer and hope it's the right thing. Yep. Right. Respiratory rate. Excellent. Well, you can get both sometimes in life. You only get one thing. Well, if the patient is totally passive, right? The ventilator has like control of everything, and then you can. Most of the time, the patient is not passive and he's actively breathing. So yes, sometimes if the patient is increasing the respiratory rate, as you've seen in the ventilator trying to keep the minute ventilation, so it will reduce the driving pressure. And I understand the more the respiratory rate will increase, actually your inspiratory time will shorten. When your inspiratory time shorten, actually your tidal volume might shorten if your flow is not hitting back to zero. So your tidal volume might reduced, and actually the ventilator has to apply with the pressure goes high. Asynchronous happen. I'm not saying those ventilator modes are perfect in preventing asynchronous, especially with So I mean, I don't like the fact sometimes that I do not control the I time. So sometimes I will be in ASV and the patient is breathing 30 and it's giving him I time like 0.6. Now the pressure has to go up. I say, okay, well, if I switch to pressure control and increase my I time to get the flow down to zero, my tidal volume will increase without even increasing the pressure. I might actually decrease the pressure. So it's not perfect, I guess, not perfect work. Oh, I don't know. Do you know that? Well, I mean, they will control, like, I mean, you will get whatever results of frequency. I think this is a sign for us to say, okay, just stop.